who needs no introduction in the field of endospine. He is famous practicing endospine surgeon and at Cheer Multispeciality Hospital, Ahmedabad. I request Dr. Anupam Sachan to welcome our Chief Faculty, Dr. Shiraj Munshi. He is famous practicing endospine.
Please, sir, take your seat. Please, sir, take your seat. We are deeply grateful to welcome Dr. Suniti Pandey, Professor Head Anatomy Department, GSV Medical College, Kanpur. Her wisdom and encouragement remain the guiding light to all of us. I request Dr. Richa Agarwal to welcome Dr. Suniti Pandey. Thank you, ma'am. Please take your seat.
We are truly honored by the gracious presence of Dr. Vedpal Yadav, Professor Orthopedics, Maulana Azad Medical College, New Delhi. His commitment and contribution to the spinoscopy is a great inspiration to all of us. I request Dr. K.K. Sachan to felicitate Dr. Vedpal Yadav. Next is you.
Now we welcome Dr. R.S. Gangwar, who is a professor in geriatric ICU DGMH. And I request Dr. K.K. Sachan to please felicitate him. Thank you, sir. Now we welcome Dr. Nidhi Gupta, Associate Professor, Anatomy Department, GSVM Medical College, Kanpur. Without support of Dr. Suniti Pandey and Dr. Nidhi Gupta, cadaveric workshop would be a dream. So I request Dr. Meenakshi Sachan to please welcome Dr. Nidhi Gupta.
I invite Dr. Rekha Sachan, Professor Ops and Gynae KGMU Lucknow, to grace the podium by the presence her. I request Dr. Nalli Gangwar to felicitate ma'am.
Now we welcome Dr. K.K. Sachan. I invite Dr. Anupam Sachan. Please felicitate him.
That's okay.
Now we welcome Dr. A.P. Singh, Consultant ENT Surgeon. I invite Dr. Richa Agarwal to please give him a bouquet. Thank you, sir, for organizing such a workshop. Now we welcome Dr. Richa Agarwal, Associate Professor, Anesthesia Department, JK Cancer and Pain Interventionist at PMSY Kanpur. I request Dr. Anupam Sachan to please welcome Dr. Richa Agarwal. Let us embrace this opportunity, learn from each other, and light the lamp of knowledge. I request all the dignitaries on the dais, please come forward and light the lamp.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिः वन्दना वन्दिता रामां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमम् आद्यां जगद्व्यापिनीं जाड्यान्धकारामहा अस्ते स्फाटिकमालिकां विदधतु पद्मासने संस्थिता वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
Thank you all. Now I invite our chief guest, Dr. H.D. Agarwal sir, to please say a few words and give blessings to us.
Dear Dr. Anupam Sachan, all my colleagues and dignitaries, this is really a matter of great honor for me that I am here with you this afternoon. This, what you are doing, spinoscopy, is really a very demanding thing for the public. As before 10 years, spinal surgery was just in our dreams, but now it has come true that spinoscopy is very common procedure being adopted by our orthopedic surgeons, and patients are benefited out of it. This is really very great achievement for our country also, and we should feel proud of it. As medical tourism in India is on the top in the world. Here, the cost of therapy is very low. Our doctors are very intelligent, very diligent, and dedicated to their work. And this is being appreciated in all over world. I know I had been in America thrice, and the doctors there, the Indian doctors are very successful over there, and they appreciate here the doctors which are working here. और मेरा कहना यह है कि आप लोग इसी तरह से keep on progressing. My best wishes, my blessings are with you to keep on progressing. May God bless you. Thank you.
Thank you, sir, for gracing us with your presence. Now we will proceed to the memento distribution ceremony. So I request Dr. Anupam Sachan to give memento to Dr. H.D. Agarwal, sir. Next. Now I invite Dr. R.S. Gangwar, sir, to give memento to Dr. Shiraj Munshi, sir. Next. Now I invite Dr. Anupam Sachan to give memento to Dr. Vedpal Yadav, sir. Dr. Anupam Sachan. Next. Sunita ma'am.
Now I invite Dr. Rekha Sachan to please give memento to Dr. Suniti Pandey, ma'am. Now I invite Dr. Richa Agarwal to give memento to Dr. Nidhi Gupta. Now I invite Dr. Meenakshi Sachan to give memento to Dr. Richa Agarwal. इसका नाम है Now I invite Dr. KK Sachan to give memento to Dr. R.S. Gangwa.
Now I invite Dr. Suniti ma'am to give memento to Dr. Nalini. Now I invite Dr. Preeti to please come on the stage. And I invite Dr. Nidhi Gupta to felicitate her. She is a consultant in SGPGI Medical College, Lucknow.
Now I invite Dr. Richa Agarwal to felicitate to Dr. Pushpalata. Thank you, ma'am.
Now I request all faculty members and organizing persons to come on the stage for group photograph.
Yeah.
Kids, please come for the group photograph. Before starting the next lecture, I invite Dr. Anupam Sachan to say a few words for vote of thanks.
Laptop.
स्पाइनोस्कोपी 2025 कानपुर में सभी प्रतिनिधियों को, डेलीगेट्स को मैं धन्यवाद देता हूं, एंड आल्सो स्पेशल थैंक्स टू all our faculty and chief guest Dr. S.D. Agrawal, Dr. Sumit Mem sir, Dr. Nidhi Gupta, Dr. Felicitation Chan, and Dr. Vedpal Yadav sir, and Dr. Siraj, and also our senior Dr. Ramji Khanna sir and Dr. Kapoor sir. Without their help, this will not possible that such an event can be organized. And a special thanks to Dr. Isha Agrawal, Dr. Nidhi Gupta, Dr. Nalini. Thanks. Next lecture. Now next lecture by Dr. Siraj Munshi sir. Tips and tricks in interlaminar surgery.
एक मिनट फोन पे ट्राई करता हूँ। नहीं नहीं ये तो चल
एक सेकंड वहां से कनेक्ट कर।
पूरा नहीं आ रहा।
पूरा नहीं आ रहा, थोड़ा सा दिक्कत है इसमें। हाँ हाँ ऐसे ही आ रहा है, प्रॉपर आ रहा है।
प्ले से पता चलेगा। नहीं इसका प्रॉब्लम नहीं
अभी तक सब चल रहा है उनके
चलेगा।
एक मिनट, एक मिनट।
Okay. Uh, Good afternoon, everyone. So first of all, I'm very thankful to Dr. Anupam, and this is my second time. I think before a couple of years I was here, and we did the first workshop. So now uh, about my today's topic is about the endoscopy. So we all know that endoscopy, there are two way of doing the endoscopy. One is for the discectomy. So usually when somebody is having the disc herniation, we do the disc removal, and the other option is to do the decompression. So in the decompression, you have the option to remove the area or the structure which are compressing the patient, the nerve and the spinal cord. So usually we prefer to do more of a monoportal endoscopy because it has certain advantages. So like very simple, if somebody asks me that which is your option, that when you select transforaminal or when you select interlaminar endoscopy. So I have a simple answer. If I have the disc herniation, I will always go for the transforaminal. And sometimes the disc is such at a place where like the access to the transforaminal is difficult, then I go for the interlaminar endoscopy. So this is like when somebody is having the acute disc, the transforaminal is a better option. Now with the chronic disc and from the site of the disc, we can also do the interlaminar endoscopy and we can remove the disc also. So those patients who are having the radicular symptoms, so like those who are having radiculopathy, usually they have active compression on the nerve, and then removing the disc is a better option. And those patients who are having the claudication, so means it has developed over the period of time, and usually you ask them how about the standing or walking, and if they have gradually worsening walking and standing time, then usually the compressor is on the posterior side. Then we prefer to do the interlaminar endoscopy. So let us see how we go for. So like both of this endoscopy we do under local anesthesia, and especially in monoportal endoscopy. इसको बंद कर सकते हैं? पूरा flow इधर आ रहा है. So especially in monoportal endoscopy, you have the dedicated irrigation channel, and because of this dedicated channel, you that your because we need a fluid medium while doing the surgery. So this medium, there is a irrigation continuously going on, and this irrigation can take the wrong path, and then you never know that where it's going. So sometimes it's create a lot of trouble because in monoportal endoscopy you have the working channel, you have the irrigation channel, so the fluid management is quite better, and a chance of complication related to fluid is less. Second, this fluid depend upon the pressure it can absorb. and this absorption of the fluid can lead to the dilutional hyponatremia, volume overload, and it has its own consequences. And the third is this fluid will go to the epidural space. So in a long term, depend upon the patient's position, depend upon the pressure, depend upon the height of the your fluid, it can go and it can compress the spinal cord also, and patient can present with either like neck pain, or in a advanced stages, patient can have the convulsion also. So usually in transfemoral endoscopy, our target is disc. So we go through the natural orifice, through the intervertebral foramen. So we go inside, and the idea here is to remove the disc bulge. So usually we have to see that from where the disc has bulged out. So basically, whenever there is a disc herniation, this goes out with the pressure. So there has to be annular tear, and through the annular tear, the disc will go out. So now what will happen? Whenever the disc go out with the pressure, so there is a very tight neck of the herniation, like neck is holding the herniation. So if you want to remove it, you cannot just pull it out because the neck is very tight. So basically in transfemoral endoscopy, we go inside the disc and we make this annulus tear wide. So we do a good annulectomy and make this herniation or make this neck of the herniation wide. So now the fragment will become free, and then you can easily pull out that herniation. So this is a fundamental principle of endoscopy, transfemoral endoscopy, that you have to do a good annulectomy to free the herniation, and then you can just hold the herniation. So it's like a mouse and tail. You just hold the tail and the entire mouse will come out. So suppose if you just go at the tip of the herniation and then just try to catch it or hold it to something, it will not come out. So second thing is, because of you are using the natural orifice, so you have the advantage that you are not creating any artificial artificial entry. And the third thing is, you can work on the same side of the disc, you can work on the opposite side of the disc, and you can remove the all possible herniation. So means like you can remove the herniation, and also since you go inside the disc, you can remove all possible free fragment. So suppose if you are not able to remove this free fragment, so this free fragment will become like a chance that it can herniate out later, and you have the recurrent herniation. So that's why if you want to do the discectomy, so just removing the tip of the herniation is not the success. You have to remove the tip of the herniation as well as the base, because base is always giving the more pressure, and you have to remove all the free fragment inside, so you have a less chance of having more of a recurrence. And the another advantage is, like when we go through the transforaminal, so we use the facet as a lever. So like your cannula is resting on the facet. So whenever you want to go more dorsally, you can just pull it. So you can use the facet as a lever, and when you go inside the annulus, so annulus will hold your cannula. So annulus will act as an anchor. So your cannula is not a free floating cannula. Your cannula is quite fixed with the annulus, and since we dilate the annulus, so there is very less injury to the annulus. So by the time when you remove the cannula and dilator, this annulus will fall back and it will seal. So with the transfemoral endoscopy, we can do the lot of things: discectomy, foraminotomy. You can take care of the recurrence disc, especially on those patients who are having the infection. So the transfemoral is one of the most important. Transiliac, so especially those who are having the L5S1 high iliac crest, and those who are having the central disc herniation. So even with the interlaminar, you have to retract cord a lot, and then removing the central disc, it's little risky because you have to stretch a cord a lot to reach to the center. So here transiliac is also a very good option. Mild to moderate lateral canal decompression, you can always. And nowadays the olive, so you can put the cage through the transforaminal route. So that's why now this has become one of the most useful approach. So I will just give you one by one. So like you see, you can and the one most important advantage is you can provoke the pain. So like in transfemoral endoscopy, you go inside the disc and you can just pressurize the disc by doing the provocative discography. So once you do the discography, it's very easy for you to find out that this is a disc is a pain generator or not. And we all understand that discography has a more positive value as compared to even the MRI or even contrast NS MRI or even the stress MRI, because here actually when you inject the contrast inside, when you inject the medication, so this will increase the intradiscal pressure and you will be able to find the same annular tear. So here the important is also like we always have a patient who are having the MRI before maybe 1 month, 2 months, 6 months or something, and sometimes if you don't have a very fresh MRI and the patient has developed a new symptoms or patients are not aware. So here you may miss the fragment, maybe like a small looking disc. Now it has become big, and your thought process is always going on about the MRI which was done 1 month or 2 months back. So here this is a real time and actual on the spot diagnosis. So like when you inject the contrast, so your contrast will feel the space. So if you have the bigger herniation, those bigger herniation will not take the contrast, so you will find a big filling defect, and this big filling defect is your herniation. So you can get the idea, oh my god, this is going to be there. So that is helpful. Second is like you can see this is always under the local anesthesia, so you can see the patient is awake and you can see the things nicely. So you can see this is one of the most beautiful picture, and you can see I'm asking the patient. So here, when the patient is awake, you can immediately ask the patient that how are you, how you are feeling. So even you know the end result also. That patient will say that my pain has gone and or my pain is there, and then you can see the free pulsatile route also. So undoubtedly, the discectomy by the transforaminal approach is the best way, because not only the tip of the herniation, we have to remove all the possible free fragment. You can see here, these are all the some of the fragments are actually within the disc and they are the free fragment. So if you don't remove it, they are going to come out in next future and then the patient will have the recurrence. So with the transforaminal, actually you can clear all the degenerative portion of the disc. Now, with the foraminoplasty, so like especially you see when you have the patient who are having the exiting root pathology, those who are having the collapsed disc, or maybe those who are patient who are having the previous surgery, so now the disc will collapse. So this collapsing will push the superior articular process inside, and it will pinch the exiting root. So especially when you have the exiting root pathology, so we always have to consider and we always have to see that that exiting route should be free. So like see, a route can compress at two level. One is at the exiting level and one is at the traversing level. So if my patient is having the L5 related symptoms, so I have to see that this L5 related symptoms is because of the route is compressed at the L5S1 exiting area in the foramen or at the level of L45 traversing area. So that way I decided I plan. Suppose if I'm not sure, then I do the both of them. So I do the L4 5 traversing root decompression as well as the L5 exiting root decompression. That is the complete decompression for the patient. So you can see like here with this transforaminal, you have the special bar, and this is the angle bar. It can go up to the 30 to 45-degree angle. So here you have the option. You go through the transforaminal endoscope, and you can just bar the tip of the superior articular process to make the nerve root free. So like this is a straight bar, and then after going inside, it will just come up. So you can see nicely. You will be able to drill the facet, and this is one of the most important aspect, and the patient will benefit a lot. Otherwise, for the exiting route compression, the only option you have is a checkup. So you have to put the cage and you have to make the foramen bigger. So like that is only the indirect decompression that will help for those patients. But with this with the help of this, you can do a nice foraminotomy. Now, even with the transforaminal, you can do a nicely lateral canal decompression. So you can see here, that this one is the cord is pulsatile. So we are through the transforaminal, and you can see I removed all the ligamentum flavum, and I'm inside. So actually you are able to see the ventral to the cord, and that way we have decompressed everything. So like patient was having the very big herniation, and like it was going inside. So you can see the entire cord and the lateral canal is completely decompressed. So like you go through the one of the foramen, and then you decompress this. So this is one of the very nice video which is showing the complete decompression. This is also same. You can see the decompression of the foramen and the things inside. Now, this is also like some of the patient who are having the already having the fusion, and sometime like they have either the foraminal bulge or they have the disc bulge. So you have the option of doing the transforaminal, and then you can do the 1 or 2 level. And this becomes easy. Otherwise, you have to do a big surgery and extension of the fixation. So that way the things become more and more difficult. So you can see this patient was having so many level fixation, and then CC develop adjacent segment disease, and like we just did the decompression, and it can give up because you are not destabilizing the spine further. So definitely there is no need to do the advanced fixation. And especially, yeah, same way, recurrent disc after the posterior midline surgery also. So like this is also very common. So this is especially happens when you remove the actual herniation which is seen on the MRI, but there are some free fragment which remains inside, and after some time it may come out, and this can have its consequences. इसको बंद कर सकते हैं पूरा बिल्कुल इधर ही आ रहा है. And this is a transiliac approach. श्वेता ये एक बात करो. So in transiliac approach also, this is one of the best indication for the L5S1 central disc, because you can go through the iliac bone, and then you can go inside, and you can remove the bulge. So you can see we have gone through the inside. So you just target, and see, you can take the lateral entry. So especially for the L5S1, if you take the lateral entry, iliac crest will come in between, and then you have a problem. But doing the transiliac, you just concentrate on the fragment and go more flat, and it will just help you. And this is about the transpyramidal cage placement. So like now we are doing more and more number of endoscopic fusion. This was way back in I think 2019 or something. So you do the discectomy, you do the end plate preparation, and then you put the guide wire, and through the guide wire you can pass the cage. So this is also like one of the most standard procedure now. And the actually the fusion is much better here, because you put the cage oblique, so you can easily put the big size cage, and then you have the very nice end plate preparation. You can see the end plates are oozing, and then you pack with the bone graft, and then you do it. So the design of the cage. So actually we develop this cage, and these are the different sizes. So it comes from 8 to 14, and you have 25 and 30 millimeter length. And you can see this is the final picture. And this is actual like this is how the incision looks like. So believe me, like within 4 hours the patient can be discharged. And this we do it under epidural analgesia. So yeah, even you don't need to keep the patient for GA. You can easily do this with the epidural, and usually the patients are very fine. So you can see this is the final picture again. So even we do like more level, like you see this patient was having the 3 level lytic listhesis. So we did it 3 level fusion, And you can see this was the cut to the patient, and this was a very heavy patient. So again, this is a good advantage to the patient. And especially, yeah, this is one of the very good indication that when you have the patient who is having the discitis. So now with the discitis, it's very easy for you to just go inside the disc, lavage it, take the sample. So the sampling will help you to identify the organism. It will even help you to identify that which antibiotic is going to work. And then you have removed the pathology, you have removed the cytokines. So even you don't need a big fixation or something for this particular patient. And see, like this, you can do it, and usually the pain relief is also significant. So this is one of the very good indication for doing the uh, uh, and see, like we can do this extend for the thoracic level also. So you can see I'm taking the distance from the midline, and you can take a CT scan, CT guided. So like see, you can see that this is exactly 3.675 millimeter. Then you can go inside. So then you go inside, and you remove it. Yeah, so like you can see, otherwise this patient require a very big surgery, and usually the pain remains. But here with the lavage, you can remove all the pathology, and usually especially for the tuberculosis patient, it will just heal, and the patient is quite pain free. Otherwise, it take around 1 to 3 months for them to have the pain relief even after the surgery, because the pathologic organism will not completely wash out. But with this technique, it's a better option. And this was the patient's follow-up, so I'll not go into the detail. So now about the interlaminar endoscopy. So like usually I reserve the interlaminar endoscopy for unaccessible disc, or for the posterior stenosis. So especially for the canal stenosis, you have the advantage that you can apply it to cervical, thoracic, lumbar area, all the level. You can do the unilateral as well as the bilateral decompression. You can do also the discectomy also, and you can do the posterior foraminotomy for exiting root pathology. So like see, this is like yeah, this is just we did it on last Sunday. So you can see the patient was having uh, the bilateral compression, and you can see this is over the top, the both side you can see, and I am doing the foraminotomy also. So you can see the you have the best advantage that with the 15-degree angle you can actually see the structure below the facet also. So you just have to change, like you see now this is a visualization from here to there. If I just change the endoscope, then you see how the visualization changes. So I just have to move the endoscope from this way to the other way, 180-degree, and then you can see the structure nicely. So uh, so here you can actually have a very good foraminotomy also, and you can see exactly how the root is going inside, and how much is the compression. Uh, so like see here, everything looks fine, but the moment I change the scope, I'll be able to see a big, uh, yeah, the bone here. You can see. So that is actually pinching the exiting root. So I'm just removing this one also, so that will help you. So you see this I can visualize because of I can change the endoscope, and this is like a foraminotomy, and now you can see the root also going inside. So this is like a complete over the top bilateral decompression with foraminotomy also. So again, like this is the same video, and like this is also one of the very interesting case, like where the patient was having foramen narrowing because of the bony compression by the superior articular process. So like here how we land. So this also I do it under local anesthesia. So this is how we are landing. This is a spinal needle, you can see, and so I have just anesthetized the entire tract, and then you put the dilator. Yeah, so you can see I'm just infiltrating over the facet, and then I just confirm where is the, yeah. Yeah. So you have the endoscope. So like you can drill the superior articular process, you can drill the isthmus, you can drill the lateral part of the transverse process also. So now you see this is how we change from one to another structure, and I'll be able to show you exactly how it looks post-operatively. So you will be able to see the entire bone which was there and the entire foramen which was narrow. Now it has already decompressed. So so you see again for this particular patient, otherwise you need a big fixation and surgery. But here you can see now the foramen is quite wide. So like I always say this that like see the everyone just try to claim that my technique is better, and then those who want to pursue their career in endoscopies, they are a little confused that which technique is superior, and then they're confused which technique is to learn. So I believe that we have to learn all the techniques, especially at least transforaminal and one of the interlaminar. So you can go for UB or you can go for the monoportal, but there are patient indication is more important because like see if I have a simple disc herniation, I don't want to drill the bone, and I want to expose the ligamentum flavum, and then I will retract the nerve and the dura, and then I will go inside and I will remove the disc. You have the natural orifice, and you can just go through the foramen and you can just decompress the nerve. And yes, out of all a surgeon factor is most important. So like suppose somebody is more comfortable doing the desk undo, or somebody more comfortable doing the microdiscectomy or tubular. So and if you are able to deliver the results, so you don't need to change. You change it unless you are not able to satisfy yourself and your patient. Otherwise, the result matters a lot. So like I always say, the surgeon factor is most important in spine management. And suppose if I am not able to deliver the result with some of the technique, then I should continue doing my technique because I already have the good experience about my own technique. So that's all the message I want to give. Thank you. So any questions? Okay, so we are moving to the theater, and we are performing uh, surgery. So let me go there, check the patient, and then I will. So we are relaying the surgery over here. Thank you.
Hello friends, welcome after the tea break. We'll see some videos and we'll discuss what we do in interlaminar endoscopy. I think it's better to make it more interactive if you want to learn. Delegates are not yet back. I can see media persons are here. Welcome, sir. Welcome to the uh, s- endoscopic spine surgery as we discussed in the morning. It is future because we don't want spine surgeries to be open spine surgeries like we did it in last decades. Now people are moving for minimal invasive spine surgeries. Less invasive is better, definitely. नहीं चल रहे तो मेरा लैपटॉप लगा दो उसमें चल जाएगा लेकिन उसका एप्पल है ना एप्पल सबको चला अच्छा नेक्स्ट नेक्स्ट कुछ कैसे करते हैं एक साथ हाँ हाँ कर दो ना वो तो ज्यादा हो जाएगा ये बता एप्पल मुझे यूज करना है First picture you are going to see whenever you dock over a spinolamellar junction, there is a lot of fat and tissue which we don't know what it is. We have whenever we palpate, it is the bony landmark. We should not miss the bone because there is dura. We can forcefully introduce this probe into the dura if we are not at the correct level. So identification of bone and exposure of the tissue is very important. It is a raw, unedited video. We have started monoportal and probe is, we are trying to ablate the tissue. It goes slow. It takes around 15 minutes to remove all the tissue and then only we can go inside to drill the bone, the lamina. So first we have to identify the bony landmarks. This is how we ablate the tissue. We are very superficial. So we are in the muscle plane. This looks big, but it's a very small muscle. This is case of stenosis. So there is hardly any space. Instrument can also not be accommodated inside the canal. फॉरवर्ड इसी से होता है ये दबाते रहेगा ठीक है There is a bleeder and we have to coagulate. This is, we are using plasma, bones plasma. So after we clean this lamina, we start drilling and then comes the ligamentum flavum. Dr. Shiraj Munshi is doing this work also under local anesthesia. That's a paradigm shift because we are doing it under general anesthesia. For geriatric population, there are a lot of in patients in geriatric population. So it's very good if we can do it under local anesthesia. The trick is 5 ml lignocaine and 5 ml bupivacaine. He makes a cocktail and put it in the facet, so upper lamina and lower lamina, 3 places, only ipsilateral. So this is IAP. The lamina here is very thick. So it cannot be cut with the carison, but need to be drilled. There is a lot of soft tissue which bleeds on cutting it. Now we can identify the ligamentum flavum beneath the lamina. This is ligamentum flavum. This all is ligamentum flavum. And there it is the bone. This is IAP. What we are using is a Spinoscope. It is 10 millimeter outer diameter and working channel is 7.1. And this carison is 4 mm. So we can take a bite, but it's very difficult and it will break the carison. Carison punch is 4 millimeter. At this time, we can push the sleeve down. So ligamentum flavum will be easily exposed. We are struggling to cut the lamina with the kerrison, which is not possible because it is very thick. This is curate to get inside the ligamentum flavum. We are trying to find the cleavage inside the ligamentum flavum. We are approaching the lower lamina now. This is the cutter for ligamentum flavum phlebotomy. We can make a rent inside the ligamentum flavum. If I remember correctly, this is not a stenosis case, but a disc case. So we are not doing a bony work here. We are not using the drill. We are just removing the ligamentum flavum and opening the ligamentum flavum with the cutter. Once we make a small opening, we can put the kerrison inside and then remove the ligamentum flavum piecemeal. This is only the superficial layer of ligamentum flavum we have removed. Now whatever is visible is only the ligamentum flavum. This is after we have pushed the sleeve inside and the only tenting of the ligamentum flavum inside the sleeve is there. Can you appreciate the cleavage? This is the cleavage between the both side of ligamentum flavum. That is ipsilateral is this side and this is opposite side. So we are trying to negotiate our instrument inside this so that we can remove the ligamentum flavum on our side, ipsilateral side. So for disc patients, we need not to drill the bone, not much, only the ligamentum phlebotomy, and then retract the root medially and go into the disc. This is deep layer of the ligamentum flavum being removed. Now the fat is visible underneath the ligamentum flavum. This is the fat. This is epidural fat. As soon as we remove the this bite of the ligamentum flavum, water goes in and push the dura anteriorly. So accidental rupture of the dura is prevented with the flow of the water. Now this is the fat and root inside. See these epidural vessels, but this will bleed unless we coagulate them with the RF probe. So this is only 22 minutes from the starting of the case, and we are there at the root. If we negotiate our nerve root retractor on the lateral edge of the root, will redirect it medially. This golden fat is epidural fat. This is how we coagulate, but the setting should be reduced to 2 in the plasma, and if RF it should be decreased again. Otherwise, there will be thermal injury on the root. Here we are using RF, just buzz and remove it. Not putting it and using it for a prolonged period. It will cause a thermal injury. And then removing the lateral aspect of the ligamentum flavum. This is when I turn the scope. So tip of the instrument is visible. This way. This is 15 degree. We have turned it upwards so that the tip is visible. This is on the lateral aspect of the lateral recess we are approaching. Okay, sir. The only precaution is depth perception. We go in and we have to see that tip is visible, and we are pulling the ligamentum flavum upward. So the dura should not be pressed downwards. I think it's time to take questions and make it more interactive. This is interlaminar endoscopy for disc disease. It was a paracentral disc. That's why we used interlaminar endoscopy. Otherwise, as Dr. Shiraz said, for disc cases, we should go for transforaminal endoscopy, and central disc is most approachable from the transforaminal because it's a natural orifice. Transforaminal, we can lead to the disc early. So we need not to do ligamentum flavum removal, not need to do much of the bone work as we do in interlaminar approach. If stenosis is there, we have to go for interlaminar. That's better. Interlaminar we can do with distendu, which is a dry system, and then monoportal weight system, that is monoportal endoscopy. And as Dr. Chanak is doing UBE, which is unilateral biportal endoscopy. I think unilateral biportal is very good, but learning curve is more than monoportal. Uh, in fact, orthopedic surgeons are doing unilateral biportal because they have everything available with them. That is 30-degree scope, which we routinely use for knee arthroscopy. That can be used with the same cautery and burr system, like shaver system we can use for UV. But for this interlaminar endoscopy, we have to purchase separate equipments like RF or plasma with a long probe, or bipolar cautery with a long probe. and drill system, which is again very expensive. We have few like Nuvag we have displayed in the MP medical system. Just check it. This is very effective because good system if you use, it'll be easy. Your surgeries will be easy. Otherwise, it's very difficult because spend time in removing the bone with Carison, and Carison it costs around 80,000 and it gets broken very easily. If the lamina is very thick and you take a bite, it'll break. As in the morning, I told you, it cannot be learned with the lectures. So it's waste of time to take lectures. Yes, we should know anatomy, and I know every one of us is dealing with this spine anatomy for so long from day one in anatomy, and now you have completed your PG and you are in practice. I think pain people are very well versed, well read for transforaminal. They are more inclined for transforaminal because they are doing needling and spinal things more often. But in orthopedics, we are doing open spine surgery, so we tend to put pedicle screws by opening all the. We have seen the posterior anatomy more. So I think orthopedic surgeons try to learn interlaminar faster. The transforaminal is a bit difficult for us to understand. Maybe it's 3D in the mind. I think we can connect to the OT if there. Okay, it's visible. Mm-hmm. यहाँ से कनेक्ट कर दो, हम एमआरआई डिस्कस कर लेंगे उनसे ना, इसमें अगर आवाज आएगी तो. Hello. Hello, are we connected to the OT? We can discuss the MRI images. Yes, patient is having neurological claudication. Patient is well-known personality of Kanpur. So our surgeon is putting a cannula. Good thing is we'll see this case under local anesthesia only. इस माइक से आवाज जाएगी ना सारे. अच्छा, तभी हंस रहे थे शिराज बहुत सबके.
check, 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 check one, check, 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 check.
अभी उनका ही समय है पर अभी 15-20 मिनट लगेंगे डॉक्टर साहब ने कहा अभी मैंने एनेस्थीसिया दे रहे हैं पेशेंट को
एनेस्थीसिया नहीं देते
अभी 15 मिनट रुको हाँ आ रहे हैं आज तो आए थे
Sir, in case of transforaminal, sir, at the level of L5 and S1, sir, there are some challenges, I think, complications when comparing to the L3 and L4 doing. So, what are the challenges or complications at this level when doing the transforaminal endoscopy? So better go for an intralaminar approach for that level is. Another one, there is a in case of जैसे central और जैसे पैरासेंट्रल जैसे डिस्क इंट्रूजन को जो पहले जो मैंने पूछा था क्वेश्चन एक क्वेश्चन पूछा था इंटरलैमिनर और ट्रांसफोरल में कौन सा यूज करना है आपने बोला था बेटर वर.
Hello, Vedpal. Hello, Dr. Vedpal. This is Dr. Siraj here.
You are audible, sir.
Okay, just concentrate here on the MRI. Vedpal, can you see the MRI picture?
Yes, sir. Just
Okay.
zoom in a bit.
Yeah, यहाँ पे दिखाओ ये. So you can see this is a classical case of spinal canal stenosis, and you can see this canal is very narrow. There's a very severe hypertrophy, and I can see there's some facet capsule also. So now he has more complaint. So like after walking for 100 to 150 meter, he feels he is becoming weak, and there is a slight instability on X-ray. So the idea is to just to do the decompression and see if in this particular case for me the facet is important. So you can
Yes.
see the facet is not completely vertically oriented. So I can just go inside and I can just remove this tissue, and so this will make the filament bigger. I already explained him that since we are not removing the disc, so disc is again keep on providing the stability, but there are chances that in the degenerative process it will worsen the instability. So in that case we can do the fixation. But here the most important thing is if you do the posterior decompression and if the patient is improving and the instability is not worsening, and since we are not removing the disc, so disc is going to keep on going to provide the stability. So in most of the cases you don't need the fixation. So mild instability is not the ideal indication. So like there are two, three favoring point to me. The facet is not completely vertical and the disc is not that bad. And the disc height is also good. So you can see the disc height is also good. So, so that way I can just start here and I can just do the decompression and
Yes.
most of the time it works. So this is a very good case where most of the surgeon will think about doing the fixation, but you see the fixation is having its own issues in terms of adjacent segment and implant issues and implant failure. There are so many things. So now suppose if you just do the posterior decompression and if the patient is fine, there is no need to go for uh, the fixation. And see now even we do the fixation also with the olive technique. So like now the fixation is not also a big problem. So you can see this lateral canal is more important here, and I can see there's some of the facet capsule also. So this will look as the white structure while we do the endoscopy. So I'm going to use a special endoscope. This is like a 100 mm endoscope. Kishore, you want the things? Hmm?
Which side we are going through, sir? Left or right?
Yeah, so initially he said that he had the complaint more on the left side, but
Okay.
the symptoms are more on the right side. So like he has this both area is becoming numb and more radicular component is more on the right side. Even
Yes.
I'm convinced that on the right side there are more compression. So I'm going to go from the midline and I will do both. I will do like a bilateral decompression. So I think it will just take a short time. So Vedpal, you can just explain that how we do the docking. So, for the bilateral decompression, we'll be going more towards the midline, and for the
Yes.
unilateral decompression, we try to go more on the one side. And I can see the X-ray. So he has a good interlaminar window. So our bone work will not be too much. But yeah, this is a tight stenosis. This is a long-standing stenosis, and especially in stenosis, the long-standing vascular congestion is the reason the patients are more symptomatic while standing or walking for some more time. So that way, they have the problem. So you always expect a good amount of bleeding in case of the tight stenosis, because this vascular congestion will always correlate with the duration of the symptoms, and also the severity of the symptoms. So yeah, so like our target is to dock on the spinolaminar junction, and then we go and we will find out the age. We put the endoscope, so we will just ablate the tissue, and then we will find out the age. And once we see the age, then we will start the drilling, and drilling will do it till we find the age of the flavum. So then once we find the age of the flavum, so we will just try to expose the more and more flavum. So this will give us the exact idea how much bone work we need to do it, and then we use the Kerrison. So with the Kerrison, we will have the control bone removal. So again, the ligamentum flavum will give you the option how much to expose the bone, and then root and the dura, that will give you the idea that how much decompression is required. So that is ultimately plan. Again, there is no fixed thought process that how much drilling or how much. So like drilling till you expose the ligamentum flavum on the midline, on the lateral side, and on the inferior lamina. So, and how much to remove the ligamentum flavum? So till you are able to see the lateral margin of the root, that is your idea. Okay, so there is no fixed rule. Everybody asks the question, how much drilling, how much drilling? So no, drilling is there. You reach the ligamentum flavum, and you see the ligamentum flavum in person, and then you just try to separate. So normally I don't like to do the interlaminar decompression. I will just expose the ligamentum flavum with the scissor or something. Then the ligamentum flavum, which is attached with the bone, which is inside the bone, you will not be able to catch it. So ideal way is to remove the ligamentum flavum by completely detaching it from its origin. Okay,
Yes.
so like you see, the patient is completely awake, and we'll just put the epidural. Okay, sure. Okay. Hmm. Hmm? Yeah, चल रहा है. Yeah.
There is sacralization on X-ray, I think, if you can see the X-ray.
Hmm. No, I
Not
don't.
much. Yes.
No. It's not there, because I can see the transfer process is completely free.
Sacralized है थोड़ा सा.
But you see, in every of the patient, we always have to ask the one question to us, that why this patient develop this particular level stenosis. So
Yes,
there
sir.
has to be some ongoing pathology, ongoing micro instability, That's why this level is getting more stress, and that's why the ligamentum flavum has got hypertrophy.
Correct.
So always ask this question that why this patient developed this. So that will give you the inside story, and at least we have to prevent those ongoing issue. So that will help you a lot, because otherwise you just concentrate on the pathology. So like see that there are many, like I always see that the patient who are having the disc herniation, so either they have a past defect, or they have a sacralization, and sometime most, not sometime, most of the time I see the patient come with MRI and everything, and basically they don't have any X-ray, and especially the dynamic X-rays are not there. So in one particular position, this the lytic listhesis will also not be seen, because you will see there is no defect. But when you just do it, when you just take the X-rays and everything, you'll be able to find exactly where the problem is. So always try to find out the cause, that why this patient. Suppose sometime the patient has some history of big weight lifting. So okay, that is the cause. Sometimes the patient has an accident, fall down. Okay, that is the cause. So you always try to see that why this patient has the symptoms. सारे मत निकाल, सारे मत, मैं दे रहा हूँ, अब खबर से सपोज दूसरे सर्जरी करना होगा तो फिर नहीं रहेगा ना अपने पास, जो चाहिए वो निकालेंगे ना, इसके लिए तो ईटीओ है. So I'm just utilizing the instrument which are absolutely required, because there definitely no need to remove everything. ये दोनों दे दो, मैं बोलता हूँ. डायलेटर डायलेटर दिया वो 10 mm का. अब आके सुन. हम्म. हम्म. चलो ओके, बस ये अभी निकालने की जरूरत नहीं है, चाहिए होगा तो मैं बोल दूंगा. क्यूरेट ले लिया ना. ओके, गिव मी स्पिरिट. चलो स्पिरिट दे दो. बस 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 चलो, किशोर लोकल ले लो. गाँव में ना. चलो एक्सरे में कौन है? somebody come for the x-ray. सर ये पीछे बांधिए. सर ये पीछे. चलो लोकल ले लो. ड्रिल आ गया, ड्रिल आ गया. आरएफ प्रोब ले लो. और ये बड़े वाला प्रोब है. नहीं 7.1 है. हम्म. 7.1. हाँ, हम 10 mm वाला स्कोप यूज कर रहे हैं. हम्म. वो जो निकलेगा वो. लोकल. चल मिल लो. नहीं नहीं वो सब कर लेगा कुछ और। चलो ओके, एक्सरे कौन दे रहा है? So Vedpal, I'm using this 10 millimeter scope.
Yes,
It
sir.
is a 7.1 millimeter working channel.
16.
So yeah, so I can use this interlaminar probe also. So I will be faster. So I have both the scope, but I will use 10 millimeter.
Yes,
Okay.
sir.
नहीं कुछ भी नहीं करना है भैया, कुछ भी नहीं करना है, बस बताओ। पिक्चर थोड़ा नीचे ले लो, आपने घुमा दिया इसको। पिक्चर बस। Okay, so Dr. Vedpal, you can see this is our X-ray दिखाओ X-ray. This is our going to be the entry point. Yes. Picture. Picture. Okay, so Vedpal, you can
Yep.
see this is my entry point. एक सुई लगेगा, हाँ? Okay. एक छोटा सा सुई लगेगा. So we are just starting. So I'm just putting the needle. So you can see I'm quite close to the midline. Picture. X-ray. ठीक है. अभी टेबल अप करो. आई फ्लूइड थोड़ा स्लो कर दो. आई फ्लूइड ज्यादा दोगे ना, बिकॉज कैथेटर हमने नहीं रखा. So you see, I'm asking the anesthetist not to use the IV fluid a lot because we don't.
Overload.
Yeah, and we don't want to use the catheter.
Yes, sir.
After the surgery, patient can just go by himself. Picture. So now you can see this is the area where I have done the infiltration, and now take the lateral. Wait. Chalo, wait. I'll just go with the spinal needle and touch the bone. Picture. Okay, fine. यहाँ पे किसका फेस आ रहा है वो तो चल. एक मिनट, एक रुको. So I'm already touching the bone here. So you see, when you infiltrate the skin and the tissue up to the lamina, then you don't need to do a lot of that is the way you can do it under local. थोड़ा बढ़ाओ, चलो. So here you can see that we are at the lamina, right? Dr. Vedpal, I can
Yes,
feel
sir.
I can feel the bone here also. इस लोकल दूसरा दे दो. ये 5 है ना? 5. So at least you should be in the line of this space. Okay, Kishore, nice. So now I'll just take a small knife and make a step. थोड़ा है ना, बाद में इनका हेड अप कर देना. So this is for the fluid. थोड़ा पता चलेगा. So whenever you make a step incision, sometimes the patient feel pain because that may not be covered fully. So you always inform. So at least they don't have unexpected pain. So you see now I'm already dock here. Okay. So you see now I can just change my scope. So you can now you can see I am on the line of the picture. Sure. ठीक है.
Yes, sir.
So now I'm putting the cannula and then picture. So here, you see, this is a very, yeah, now you take the AP. So this lateral picture is very important because this will give you the rough idea about the depth of the lamina, thickness of the lamina. AP ले लो, चलो, AP ले लो, AP. So this will give you the exact idea about the thickness of the lamina. So when you are working, you should be knowing that, okay, what exactly, how much you are supposed to drill. Okay, so you should be able to get the idea before you go for the surgery. So you know that, okay, this much is thickness is required. Okay, now you see, so now here, uh, okay, show me the picture. बस बता एक बार बता दो, लास्ट बता दो. Okay, so now you see, now I know, okay, this way, picture. This way I'm at the edge of lamina. So I should know that this picture, यहाँ पे बताओ, you see, Vetal, this is very important. It is checking here that this way I'm at the edge of lamina. So my entire surgery, I don't need to keep on taking the X-ray. Where am I? Where am I? I know that, okay, you can see on the X-ray, we are on the edge of the lamina. Okay. So now I will drill and see, I have deliberately take the incision little above because most of the time you have to do more work on the upper lamina. So that's why now I have started taking 1 or 1.5 centimeter little above the incision. So that helps me to work better. So this is a new development. Vetpal.
Yes, sir.
Yeah. So previously we were just on the edge. Then I have to work with my scope like this. But now we work like this.
Yeah.
ये सब उधर ही रखो ये पानी आएगा खराब हो जाएगी मैं बोलूंगा ये तब करेगा. Fine? ठीक है. हम्म. चल. Okay. So up you can go. Okay. इन- इनको इनको है ना 50 मिलीग्राम सुनिए 50 फेंटानिल दीजिए 2 मिलीग्राम मिडाजोलम दीजिए लेट ही मेक कंफर्टेबल. इनको 50 से 100 फेंटानिल दे दीजिए और एक है ना ऑक्सीजन का वो रख ही दीजिए नेचुरल प्रोम तो रख ही दीजिए. ठीक है. 14 दिया था ठीक है. हाँ तो सो जाएंगे. हाँ तो और मिटा दे दो. मुझे थोड़ा ब्लड प्रेशर है ना अराउंड 100 सिस्टोलिक चाहिए. हाँ नीचे कर दो जितना हो सके इतना नीचे कर दो कर दो. फाइन फैंटास्टिक फैंटास्टिक चल. हाँ ये बढ़िया है ना. ये ज्यादा बढ़िया. मैं ऊपर चढ़ के करूँ इससे ज्यादा ये कंफर्टेबल है. तो नाउ वेदपाल यू कैन सी द कैमरा पिक्चर.
Yes.
Okay. So now you see I'm just putting the white balance. Okay. Okay. So you see these are all the preparation. We are just you can see this is a the irrigation. So like I don't want to the fluid to fall on me. So we have put the this extension and this is a, uh uh special drape for. क्या हो गया उसमें एड्रेनालिन डाला. दोनों में एक एमपी एड्रेनालिन डालो. एडिया दे दो चलो फटाफट. हाँ. And see we are asking to do the head up. So this head up will prevent नहीं पूरा ऐसे करो टेबल. ठीक है चलो अभी ठीक है चलो फाइन. ओके. सो नाउ ओके चलो आरएफ दे दो किशोर. आरएफ चालू किया. थोड़ा पावर ज्यादा रखना. मैं बोलूंगा तो. ओके सो वेदपाल कैन यू सी द कैमरा पिक्चर. गिव मी 4
अभी आउटसाइड पिक्चर दिख रही है सर, बट इट वाज विजिबल.
कैमरा
कैमरा
पिक्चर.
पिक्चर प्लीज.
कैमरा पिक्चर दिखाओ. और देखो एक यहाँ पिक्चर दिखाओ और एक वीडियो पिक्चर दिखाओ.
ठीक है? So
अब
when
पिक्चर दिख रही है, इसको छोटा कर देंगे, कैमरा पिक्चर दिखाएंगे। हाँ अब ठीक है,
हाँ ठीक है.
कैमरा पिक्चर इज विजिबल नाउ।
So now first step is to confirm where exactly your bone is. So I'm just
Yes.
putting it and I'm confirming it. Okay? मुझे bone feel होना चाहिए, उसके बाद ही मैं कुछ भी आगे काम करूँगा.
यस सर।
Okay, this is extremely important before you touch any tissue, because otherwise what will happen कि आपका incision थोड़ा आगे पीछे हो गया और आपको नीचे bone का support नहीं है, then you can be anywhere. So always try to feel the bone first.
कैमरा पिक्चर इज नॉट विजिबल।
वो वहीं से कर लेंगे, वहाँ पे जो बैठे हैं ना, वो उनके हाथ में है अभी. Yeah, give me this RF. So now, Vedpal, the most important here, not to touch this tissue with the forceps. I just remove the
Yes,
some node. Now RF. So I'm doing the RF just to cauterize the tissue. So here for this particular step, I prefer 0-degree RF because that will go directly over the lamina.
yes
Okay.
sir.
So like, see, this is like this is people used to use for the bipolar surgery, and this bipolar surgery was used for arthroscopic surgery. So they are using the same vein. But here, the tissue, I am more interested working the tissue here, not on the side.
Hmm.
Okay, so because
Yes.
that will only expose the lamina. Okay, so yeah, see, once I expose the lamina, then if I want to work in the periphery, this probe is useful, but it's okay. So you can see I'm just cauterizing the tissue, so like my visualization will become more and more good, and I'll be able to do it in a better way. But you see now all this process, docking and everything, the patient is quite comfortable.
Hmm.
So that you can convince that this is possible under local anesthesia. Wait. See, my reason for the obsession of for using the local anesthesia is when the patient is awake. So we say that your awake patient is the best neurological monitor. You can get all the feedback. Patient can tell you something. Okay. So now suppose if we have anesthetized patient, so important, the patient will not be able to report you any complication, or like mostly because of the fluid, they may have a neck pain or something. And then anesthesia just masks this, they don't prevent it. And so that is the way you have a problem. So we always want an awake patient. So you can see I'm just trying to cauterize more and more tissue. Fine. This is a maximum setting. Fine, no problem. Okay. This shows off. Yeah. So you see, your chance of damaging the scope is also high with this side probe, because by chance, if you just take it out, you will just hand it on the lens.
Yes, yes.
Yeah. So again, like 0-degree probe is better here. Wait. Okay, forceps. So you see, again, I will just expose the bone here.
Yes.
So you see, the bone is just below this. So if I have a 0-degree probe, it will just burn out this one and it will expose the bone. Simple probe le lo, curve wala. So normally, Vedpal, I always use 2 probe at a time.
Yes sir.
So one probe is for uh, working to expose the lamina, and then the one probe is to work on the periphery. But now I can feel this is the facet here. So again, like if I want to remove this tissue, I will just do it, expose the bone. I will cauterize it and then I will do it. So it will not bleed. Otherwise, what will happen if you just catch this tissue and if you just try to burn it or pull it out, you will have a lot of bleeding. Wait. So I'm just trying to go more inside, and I can see forceps the forceps. So this portion is a lamina. So you see now removing the tissue is not a problem for me, and you can see this is the lamina. You can see this is a fat. So now I can do this. So I will just feel it. So again, give me the force. RF. So you can see with this direct probe, my exposure is faster because I can just touch here, I can expose it because the lamina is front of you. Okay, you can see this tissue. So this cannot be done with the 90-degree probe. 90-degree probe is good for here, this tissue, side tissue on the periphery, but not here. So now you see, I feel the bone, then I check it, I check it, I check it. So I will just find out the edge. So you see, this is the bone and this is not the bone. So then I have to start drilling here. So the idea is to find out the edge of the bone. Okay, so this is the edge of the bone. So this is my tactile feeling. I'm just feeling it, the bone. So I want to be very sure that where is the edge and then I can start drilling. Okay, fine. Okay, now I will just go inside and I will just start drilling here. So I'm just getting the tissue retracted. So I'm using this 3.7, 3.8 millimeter burr. So like see, always I feel the bone here, and then you see this is the edge. Okay, drill. So you see this is the burr. You have to hold it in a special way. So my right hand is just pushing the burr up and down. My ring finger is holding the burr. So it will prevent any slippage of the burr, and my left hand will help me to go inside. So like the position change of the position of the burr is determined by the left hand. Wait. So you can see now this is the area where we are burring.
Yes, sir. This is the lamina, upper lamina, I think.
Let me just remove this tissue so the picture will become more clear. Yeah, give me RF. I will try to shrink it with the RF or I will use the forceps. So always try to be the picture more and more clear. So you will be having exact idea where you are working. So you can see now the bone more clear. So this is the bone and this is the junction. Okay. Fine. Okay. So now you can see that we are more and more clear. Now I will again use the burr. So you see the RF requirement is quite, you don't need RF for a very long requirement. So now this doing the lamina. So what I'm doing, just making it more slopey. So my Carrison can hold it and I'm just trying to find out the edge of the lamina, final part of the lamina, where I can just go and I can just take out. So this inverted V should always be at a 6 o'clock position. That is your orientation.
Yeah, listen.
Sir, give me one gloves on my finger. No, you continue it. Gloves on my index finger. Okay, so now Vedpal again, give me RF. Goes there, goes. I'll just. So you see this with this index finger, can you see my the way of holding the scope?
Yes, sir.
So you see this index finger is pushing the sleeve to the bone. See, because of the elasticity of the tissue, this sleeve will always come out. So I have to keep on applying the pressure on my index finger. So I was feeling a little painful uh, because it was coming out. So you see, this is the way I'm holding the scope. Again, just see the
Yes, sir.
wait. See the picture. This is my two last middle finger and my ring.
Yes.
They're on the skin. My index finger, my this middle finger is encircling the sleeve. This finger is on the top of the sleeve, so it is
Mhm.
pulling the sleeve to inside. And this my thumb. Thumb is helping me to get the scope
Lift the scope. Yes. Up,
up and
down.
down and whatever. Okay, so this is the way you hold the scope. And I tell you again, for when you start it, it's not easy because your those muscles are not trained, so you will feel a lot of and you will
Tired.
like a
Yes.
cramping like sensation. So once you do it, so now you see, I'm just trying to make this area more and more clean, so you will be able to see the picture more clear, and then you can just do it. Okay. So here also you can see. Fine. So now wait. So now you can see this is the part of the lamina. Give me drill. We have already drilled. So I will just drill it little bit more. So I will find out the last edge of the lamina. Then we will start working with the Felicitation. Drill. So you can see we are using the diamond burr. So this diamond tip is having the very good advantage that it will turn the bone into the powder.
Yes.
And see, with the drill, we are using the side of the drill. We are not using the okay, so like this is a control drilling and always under vision. So now you can see I'm drilling more. I'm just trying to find out the last part of the lamina. So I will just start using my Carrison. This is I'm going toward the midline. So this is like this process here. So this also endoscope you can find out that it is having the outer layer is yellow cortical bone. The inner is more pinkish and the most inner wet is also whitish. So when I get you see this is the picture you see. The outer part, this is the outer part of the lamina. This is the pale white. Inside you can see the pinkish. And then you go deep down, it will also the pale white. So that is a cortical bone.
Yes, sir.
Drill. So you can see with the endoscope, you can get a view and you can see the bleeding and everything is quite controlled. So
Yes.
your job is quite easy. Wait. Now, again, what you need to do is this. This is the superficial phlegm. So I just need to shrink it again. So you will be see. So you see, I'm not worried about any tissue here. That I will take care later. I don't waste my time
Yes,
to
sir.
about the tissue over here or here because I just need to do something so it will expose the ligamentum flavum and then this will whole will come out, so you don't need to waste your time here. You just focus on the area where you want to work. Right. Okay, now I will still use the drill a bit so I can go more inside. So now I will start drilling more onto the to the midline side because this patient we want to do the bilateral decompression. Drill. So now you can see I am able to find out the last part of the drill. So the quality about this drill, wait, you can see the drill is not doing any effect to the soft tissue. It works only on the bone.
On the bone. Yes, sir.
So this is a very good advantage. Drill. So now this is the upper lamina, this is the middle part, and this is inside. Okay. So I will have to still work here. So you see from the drilling also you can make about the quality of the bone. So this is a good quality of the bone, what I can feel with myself. Wait. So now you see we are still going more and more inside. I will still use the RF. So I will just shrink the tissue. So you see I'm always trying to keep my eye on the edge of the
Lamina. Yes, sir.
phlegm and lamina. So once again, if I shrink it, then only I'll be able to see the edge here. Okay.
Yes, sir.
So this way you can make it more and more clear. Fine. Wait. Now you see, I know that I have reached to the curate, the last part of the lamina. So I'll just show you, but I still need to do some of the bone work because I want to do all the bone work once in all, then I don't want to do it. So like you see, this is the last part of the lamina. You can see. So with
Yes,
this,
sir.
I
Curate
can,
is going underneath the lamina.
yeah. So I can detach some part of the phlegm. Okay, irrigation. So whenever you see something like this, so the irrigation is a problem. So close the second one and just replace with another one. Yeah, no, I want drill. First give me RF, then I need a drill. So you see, you have work up to the full depth of the lamina, but I again want to expose this more area because we want to do the bilateral decompression. So this part will also require. Okay, so this is the midline. So 12 o'clock is midline. 6
Yes, sir.
o'clock for the 3 o'clock is superior lamina, and this is toward the inferior lamina.
Yes, sir.
Okay, fine. Drill. So now you see, Vedpal, I'm going more towards the midline. So this is called the over the top bilateral decompression. So I will just do my body work. So you can see the good quality drill is the
Yes.
key. Okay, and like see what you need it. Yeah, there are some other options, but they are not as good as this particular drill because this will do your job nicely. Otherwise, wait. Otherwise, if you keep on taking a lot of time in drilling, so then your surgery will take time and then you'll not be happy. And most important for me is when I do most of my surgery under local anesthesia, so I have to be really, really fast.
Quick. Yes, sir.
So I just like keep everything ready because you see, after some time, I know my patient will not be able to be comfortable lying prone, and then if they have some fluid related issues, they will be mad. So either you have to stop surgery or you have to cancel it. Wait. So better is to use the good stuff. So your job will be
Faster.
fast. Yeah.
Yes.
Yeah. So you see, I always say that, like, see, suppose if you are a neurosurgeon and you are operating the brain tumor, you need a good microscope. Now you compromise into that, you are into trouble, and it will affect your outcome, and it will affect even your further practice also because
Yes, sir.
your surgical outcome are your success. Yeah. Wait. Fine. Okay. Give me drill. So I will again drill little bit more toward the midline. So then I don't need to work again and again. Drill. Wait. Okay. Now give me calcium. And then give me first curate. So you see, now I will just try to expose the ligamentum flavum more and more. So if I'm able to expose a good ligamentum flavum, then rest of the things I will be able to do with the. So you can see This I'm beneath the lamina thrown. So I'm using the 3 size Kerrison. So you can see. So let's see. This is I can do the bone work. So here, the patient's blood pressure is also very important. If there is a ooze, so like I always ask the anesthetist to use the labetalol. So at least my field will be more clear and I will be able to do the surgery faster. So now you can see this is the ligamentum flavum here.
Yes, sir.
Ligamentum flavum is my guide. Okay. So like the question of how much to remove the bone. So till you find the edge of the ligamentum flavum. What happened? Say for example, 4 seconds what happened. So you can see ligamentum flavum now.
Yes, sir.
So now you see when you get the edge of the bone, so this is your guide. So you know, okay, where you go, where you go, where you go, okay. So now to faster my work, I use the 4 mm Kerrison. So it will help me to work faster. Yeah, this yellow part is a flavor. So now you have some oozing. Okay, just reduce the setting, RF setting. Three C kar do. So now you see this is a small oozing here. So I'll just try to control. So Vedpal, in my experience, like we have 2 scope. One is 5.7 working channel, one is 7.11 working channel. So the 7.1 is good when you have the tight stenosis because it provides a good outflow.
Yes, sir.
So your field is more clear with the bigger size scope.
Okay.
Yeah, so little bit your bony work will be more because when you want to do the over the top decompression, but it is okay because you see for this particular cases, you need to do the good decompression and the bleeding is really a trouble. So you see that's why I take my time just to work on this thing. Right. So now you can see the ligamentum flavum side
Yes,
nicely.
sir. Very well.
Okay. So you see we are not concentrating on any of the tissue which is above. But just target and our eye is on this area. So now you see this is I'm going to the opposite side. You can see. So this is I'm in the midline.
Yes, sir.
I'm just trying to work here. So I'll be able to expose this area also. So थोड़ा blood pressure थोड़ा करो labetalol दो. 3 आपने 3. So you can see that there's a lot of bone oozing. So
Yes, sir.
bone oozing is also related to osteoporosis and old age. So now you see this is I'm in the midline. Okay. Now I just want to see the below, so I will just remove this tissue because this is hindering my view for the opposite side. Okay, Carison. So now you see, I will just come on this side. This is toward the facet. So you can see I'm below the facet, and then I'm working on this. So I will not do much of the lateral work because I know that this is a little unstable spine. So ना एडीआर डाला है आपने? दोनों में होना चाहिए. Every point should have one ADR. ये जो oozing ना, see, Dr. Vedpal, this oozing will only be controlled with the adrenaline.
ADR. Yes, sir.
So using the adrenaline is good, always good. So now you see, I'm able to remove this ligamentum flavum from here.
Yes, sir.
Do it from here. So you can see also, like I'm able to work on this area. So I'm able to detach the ligamentum flavum here also. So now you can see the ligamentum flavum is almost over.
Yes, sir. Edge of the dura should be visible.
Yeah. So here, if you see the MRI closely, this ligamentum flavum hypertrophy there is not more into the center. The center is always free. It's more into the lateral aspect. So I always say that pathology of stenosis lies into the lateral canal and in the foramen area.
Yes, sir.
Okay. So now you see there's a good amount of oozing. So what I'm going to use is I'm going to use a cap. Cap आप इधर दो. So Vetal, you can see
Yes.
the cap I'm using. So the cap will provide the kind of a positive seal. So you can see my picture has become better. So now I'm not going to chase this bleeders. I will ask the anesthetist to reduce the blood pressure to keep the systolic around 100. So they can use the labetalol. That is the best medicine for this particular thing. So now you see this is our end point of our bone dissection. Okay. Because now you see the ligamentum flavum is detached here. So I will just make it little more free, and then you will be able to see the canal inside. You will see the epidural fat inside. So you see now. So this is our end point. Okay.
Yes, sir.
So this is what we wanted to achieve. We wanted to remove the ligamentum flavum. So now this is on the opposite side. So let me just try to do whatever the bone work I can finish it. I will finish it. So it will help me to do the opposite side work also. I don't use any 90-degree carison. I use always 45-degree carison. Now give me curate. So now Vedpal, I will use this curate just to expose this one.
Ligamentum flavum to be removed with the curate?
So now you can see I'm going inside.
Yes, sir.
Now you can see that my curate is I'm just rotating the curate.
Yes, sir.
Just to go below the ligamentum flavum, and then you can just do it. So now here somebody is asking me the question when you use the 45-degree and when you use the 90-degree carison. So you see, it's more difficult here to expose this curate, like expose to catch hold of this bone. So if you have this 45-degree, it can slide inside. Now for the 90-degree, you have to go in and then you have to go like this. Okay, RF. So now you can see the nicely ligamentum flavum here. This tissue is coming in between, so I just want to shrink it here. So my picture will be more clear. So I still need some drill to work on this part of the bone because I want to expose this part of the lamina, this part of the ligament. Fine. Fine. So you see, I already expected a good amount of bleeding because of nature of the stenosis. So it was a very old stenosis. So that's why I'm going little slowly, and I'm just trying to work on a way that we will do it slowly, because if I keep on chasing this bleeding, I'm not going to succeed, and it will just increase my surgical time without getting the control of the bleeding. Wait. So now give me drill. So you see, when I put this one, so I'm just trying to drill somewhat over here, so I'll be able to take out this ligamentum flavum, because this is a vertical lamina. So vertical lamina, I cannot remove it with the my Kerrison. So again, I'm making the lamina more slopey. Hmm. So see, since I have the protection of ligamentum flavum, so I'm not worried. So that's why I didn't remove the ligamentum flavum before I finish my bone work, because ligamentum flavum is my protection for my burr.
Yes, sir.
And see, whenever I want to see the structure, so what I do, I obliterate this outflow. So you can see, you just increase the pressure above the venous pressure, then you can see the structures nicely. So you can see now this is the last part of the ligamentum flavum.
Yes,
I
sir.
just want to burr somewhat over here. Drill. So you have to burr from the top, from the up. Wait. Okay, so now I will remove this part of the bone. So you can see I have this option to, no, give me Carrison. No, three. So again, here also I am just trying to find out the edge of the ligamentum fibrosus. I don't want to stretch it. I want to remove it completely. So now you see, with this I can take out the bone, because this pitch of uh, this Carrison was not is not so big, because it's an endoscopic Carrison. So what I want to do, you see, I drill it, and now I go inside, and now you see I can work with the Carrison. You can see now you can see the extension of the phloem inside. You can see.
Yes.
So
Yes.
I want to completely expose it rather than just pushing. Okay. So that my detachment will be more safe. So you see, I can come here. And then you can remove it. Okay. Hmm? No, this is ipsilateral ना. अब मैं contralateral गए नहीं अभी तो. You can see the position of my scope. So now you can see the nice exposure of the ligamentum flavum on one side.
Yes, sir.
So this is what actually I wanted to achieve. So I still want to go more laterally. So you see, without removing this bone, you cannot achieve the complete. So you see, some of the people, they will just remove the phlegm in between, and then they say the surgery is finished. The patient will not improve, because this is the main area where there is a compression. हम्म? अभी एक साइड का तो करें, पहले एक साइड का करेंगे, उसके बाद दूसरा करेंगे. पहले एक साइड का हो जाए ना, उसके बाद दूसरी साइड का करूंगा. So now you see I'm coming more and more lateral. So this is a lateral. This is I'm working on the IAP. So again, you see, whenever I want to see the nice view, so I will just obliterate and I will just check it. So you can see. So even I can see from where the bleeding is happening. You can see here.
Yes,
This is,
sir.
so this is also the bone oozing. Most likely it will not cover with the RF. So we'll use the bone pressure with the keratan or curate. So let me first try with the RF. So you see how to do is you go to the bleeder, touch it. So if it stops the bleeding, it means you are there. And then you do the RF. Give me keratan, round keratan though. So you see this is a significant oozing. So this is not round, right? Round, round. So this is I'm going to apply the pressure through the keratan, and again I will see the blood pressure. So you can see this is the bleeder. I will just press it. ओके, दोनों चालू कर दो, दोनों फुल कर दो, चलो. हाँ. और दूसरा है ना, ये दो पॉइंट यहाँ पे लगा के रखो, तो तुरंत खाली हो जाए तो दूसरा लगा देना, और उसमें एडीआर भी लगा के रखो. So now you see we have almost
It is oozing from the bone, I think.
yeah, it's a bone ooze, definitely.
Yes.
See here, 2 millimeter आपने. So sometime what you can do is also you can go below and then take out this chip of bone. That will also control the bleeding, and then keep it pressed for some time. So like you see, I'm below and then I hold it like this. So you see, Vedpal, this is a tissue which I was talking about in the MRI.
Yes, sir.
So it's a white tissue, okay?
Yes, sir.
So this I was expecting close to the facet. So you see, you really need a good RF here. So like you see,
sir.
there are two kind of cautery machine. So one is a plasma and one is a radio frequency. So the plasma is quite powerful. So I always have a big fear that with the plasma, you can actually create more thermal lesion of the neural structure. So
Yes,
here
sir.
you have the 4 megahertz RF, which is more safe here. RF, RF, सर, आवाज नहीं आ रहा. ओके, वेट, इसकी आवाज बढ़ाओ. आरएफ की आवाज बढ़ाओ, वॉल्यूम बढ़ाओ. So you see, like I was not able to hear the sound, so I asked them to increase the sound. Fine, okay, fine. Are you? Yes, yes. You see, I should be able to see where it's working. So I was not very sure. Yeah, now I can hear the voice. Because you see, normally I don't keep this control with me. I always give it to my assistant. I'm just focusing on my endoscope, so I don't want to change my position. So now you see, I'm not going to change this oozing. I'm just going to start now concentrate over here, removing the ligamentum flavum.
Yes, sir.
Okay, because you see, this is a bone oozing, and once the venous pressure will go down, it will drastically reduce. So use the laboratory because now the blood pressure is 136. लेवल है यहाँ पे and you can see Dr. Anupam is talking to the patient.
Yes, sir.
So that is the beauty.
Yeah.
So now you see this is the one side of the ligament flavum. You can see the nicely sheet of the flavum. There's a oozing here. So I just change my concentration here. Let me see. दूसरा लगा दिया ना दूसरा भी ऑन किया नहीं yeah. So you see, I know as soon as I remove this phlegm, this bleeding is going to stop because then the congestion will relieved. अच्छा, inform him, डॉक्टर अनुपम इनको बताइए कि थोड़ा पैर में कुछ आएगा. So if it is too much, now you see I'm below the phlegm.
Yes, sir.
Now I'm detaching the phlegm like this. Okay. So even like if you want, you can see the tip of your curate also. So my traction is on the upward direction.
Yes,
So
sir.
this
Yep.
is
Lifting it.
actually I'm lifting it. Yes. So that is a safety. And you see this the fluid here. I see the best advantage of using the fluid here because this fluid will go inside. So actually this will make a plane between phlegm and dura. So no, give me curate. So this will actually keep the dura down.
Yes, sir.
So that is that way uh, you have the option to lift it. So once you remove the phlegm or once you detach it, your job is done. So you can see. Now give me Carison. So now you see, curate is a smaller diameter. So with the curate, I'm not getting the good control of the bleeding. So I will use the Carison.
Carison. Yes, sir.
As soon as I put the Carison, my picture will become more clear because Carison will provide the good seal. So in fact, we have designed these instruments according to the diameter of the scope. So you see the thinner Carison are not useful to control the bleeding. Huh? थोड़ी थोड़ी बढ़ा दो. So you see, this is the oozing is coming from all the bony surface, but like it's okay. I can just now put the Carison here, and I just want to remove this Carison. ये लगा था ना? पूछा. So now you see here. So now I'm holding the bigger part of the this one. See, I can always change my scope to this direction, so I can see that I'm not holding the dura or something. Okay. And you can see this is a quite tight. So I'm just trying to hold it nicely. Okay. So now this is Now you see, now you have the advantage. In upper part, you already have detached the phlegm. So now you go in the lower part, you go like this, you go like this, you go like this, and then you remove it. So you will be able, because in the upper part you already have removed it. So now it will be just free. Now you see, you can't use the 90-degree here. Okay, so 90-degree will slip inside. And you see, like we are not obsessed with removing the end block or something. We just try to work. Give me 2 mm. So just try to remove slowly, slowly. So you will be able to see that, okay, you are just decompressing nicely. So you see, this is a superficial phlegm. This is the deep phlegm. So I will go here. Now I will work here. Okay. So this is the way I'm just opening the canal nicely. Now you see the hell of a congestion. You can see the epidural pulsation.
Yes, sir.
So, so this is the reason for his like a severe complaints, because he had the, and see now Vedpal,
Yes,
the
sir.
leader which we were fighting, now it's not seen. So it's like those bleeder will come and they will trouble you. But if you keep on chasing them, the best thing is to avoid them.
Yes, sir.
Don't look at them. Just try to work somewhere else. In a short time, it will disappear. So you see, I'm still expecting a lot of phlegm here in this lower part, because I can correlate from the MRI. 3 mm देगा, RF देखो जरा, 3 mm कैसे देगा, RF देगा, RF देगा. So you see, we still have to work little here to expose this more part of the ligament phlegm, because I cannot see the tip. So that was the tip of a superficial phlegm, not the deep phlegm. See them? Monday available fixation. So So you can see this phlegm is still having the good extension inside. Now
Yes.
I can see the deep phlegm. Okay. And I have to still remove this tissue, this bone part in the lateral area. So I'll be able to see more of a. And see, don't pull out anything without confirming it. Okay. So you can see this is a big chunk of bone with the phlegm. Okay. So now so you see the more severe and more tight is stenosis, there will be a more congestion. And in any of the endoscopic surgery, whether it's done for any other indication like ENT or laparoscopy or arthroscopy, if you have the bleeding, then you can't visualize anything. So like you have to be very careful. And any bony piece, you have to remove it. You just cannot say wait. So like see, this is my picture as of now. So I'm just trying to get the hold of the view so I can work better. So I still want to remove this lateral part of the bone so I can expose more of the level. Okay. So now you see, now I can see, Kishore, take the hook. Hook, nothing લીધું આપણે. So you see, I have to detach this phlegm, then only I'll be able to give me the કેરેશન of the. So now you can see this phlegm is ending here. You can see the defect here. Okay. So now I will use the hook just to separate this phlegm. So now you can see when I'm detaching the phlegm, now this has started pulsating. And let me just coagulate this with RF. So you can see now
Yes, sir.
pulsating.
Yes.
Like I just have to work and detach this more. So normally fat is not easily like you have to remove it with the forceps only. So I'm just trying to shrink it as much as I can. Then I will start working. And then you see this all tissue. So like this all tissue, you have to shrink it to get the better visualization. Fine. Wait. Okay. Now give me curate. So now you see with the curate, I will just go here. I'll just work here and I'll detach it. Okay. So now we know that okay, the whole the ligament of phlegm is coming out. Okay. Because now there is no attachment here. So now I will go to the lateral side and I will just try to separate it from the lateral side. So now you can see that the root and dura.
Yes, sir. Dura is visible.
Okay. So like you see, when I'm pushing it, there is no pressure on the dura, so I'm safe. Okay, now give me Teresa. So you see now once you detach it completely, now you can safely remove it from wherever you want. So I do have the option here. Go, take out. It will come out as a strips. Okay, and you can see how is the bad condition. So you see, we are not like want to remove as an end block or something, because you see these are not the cases where your end point is a decompression. That's what you have to achieve it. That's all. And you see now, I'll just see. Okay, good. Okay, good. Okay. So you can see, I'll just observe. Okay, fine. So you can see this is a big chunk. So you see, most important for me here is patient is awake. So when I touch any of the neural structure, patient will inform me. So that is the biggest safety. क्या हो रहा है? नहीं नहीं कुछ है तो मुझे बताइए. हाँ कुछ नहीं you don't. आपको I'm telling the patient we are keeping you awake for give us the feedback. Okay.
Yes.
You are the part of the surgery, and then you see we can easily make you sleep. It's not difficult for us, but when you do it and awake, so we have the feedback from you, so we can prevent any complication. So you see now I'm working on the lateral flavum. I'm deliberately not touching the this mid part of the flavum, because once I remove this one, then it will become more easy for me. Give me 4 mm. So now I'm working on the lower flavum, lower lamina. So lower lamina, the flavum is just attached on the edge. So it's you don't need to do the any bony work here. You can just क्या बोल रहे हैं? गर्दन दिख रही है ना? कंफर्टेबल है ना? You are below the facet. ऐसे पे दिखाता हूँ. So now you see, I'm just going inside, and then we are just removing this part of the flavum nicely. लिप्स लिप नहीं नहीं कॉन्ट्रैक्टर बाद में करेंगे. थोड़ा प्रेशर आएगा. हाँ, I'm just informing. So you can see the phlegm here.
Yes.
So this is all we are expecting, because this is the area where he is having the maximum pressure. Or yeah, this is the SAP. So you need a very sturdy instruments also here, because you see that I'm putting a lot of pressure on the instrument. Three. So you can see how severe is the congestion here.
Yes, sir.
Yeah, so now I'm going to use 2 mm kerosene and I'm just going to expose this whole area. So you see, I'm just trying to see that, okay, I'm safe. Okay, I can see the dura inside. Okay, this is the dura inside. Yeah. इसके नीचे dura है.
जी.
When I remove this, then I will be able to see the dura. You see here, and you can see the dura inside.
Yes, sir.
So you can see this is what we are talking about. The congestion is more and more onto the lateral side. Midline is not that bad.
Yes, sir.
So like you see, this is the dura. Okay. Yeah, it's a part of the flow.
Yes, sir.
You see, this is a part of the flow. Okay. The dura is quite deep inside usually. See, this is the phlegm. So now I'm just trying to go more inside. You can see the dura here. So I will just catch hold of this phlegm here. But this is the midline phlegm.
Yes, sir.
You can see? And you can see the dura inside. Hmm? Yeah, yeah, yeah. Hmm. No, once I remove this, then you will be able to see the dura nicely. You can see the dura now.
Yes, sir.
You can see now the root is exposed.
Root, yes.
So you can see the dura is quite safe here.
Yes, sir.
Okay. So you see, these are all the like quite tight adhesions, and these adhesions are the responsible for patient symptom. क्या हुआ? गर्दन में दर्द है ना, दिस इज बिकॉज ऑफ फ्लूइड प्रेशर, तो वो बाद में थोड़ा कम करते हैं. See, Vedpal, this is I'm talking about when
Yes,
he's
sir.
now he's telling us that neck में pain हो रहा है.
Hmm.
So this is the indication. So see, this is not like a easy case. This is a quite tight. You always have eye on the dura here.
Yes, sir.
Now you see, now you'll be able to see things are getting more and more free. But you can see this tissue here, but quite adherent. Now you see the dura.
Yes, sir.
अगर नेक का दर्द ज्यादा हो जाए तो बताना है, तो हम थोड़ी थोड़ी देर वेट करेंगे तो चला जाएगा। हाँ थोड़ी रुकते हैं, कोई बात नहीं। So you see, when he is having the more pressure, so we can wait, because you see now immediately after this he will be comfortable. अभी अभी पूछो उनको, थोड़ा 2 मिनट में ही कम हो जाएगा। अब अभी गर्दन थोड़ा कम हुआ, ठीक है, गुड, ठीक ठीक। So you see, this is my reason for
Sir. Yes.
local anesthesia, because if the patient is under GA, patient has the symptoms, but it will mask. Patient will not be able to complain.
Yes, sir.
हम्म नहीं, हाइट बढ़ेंगे तो ये नेक पेन ज्यादा होगा। इनको अभी थोड़ा है ना, अच्छे से 1-2 मिलीग्राम और मिडाजोलम देके सुला दो, बिकॉज अभी क्या हमको फटाफट खत्म करना पड़ेगा। मे बी वी विल डू ओनली यूनिलेटरल, बायलेटरल नहीं करेंगे, बिकॉज बिकॉज यू सी दिस इज द इंडिकेशन, यू कैन नॉट गो अहेड। पेशेंट को कंप्लेन है तो ये ये एपिड्यूरल प्रेशर बढ़ रहा है, इसके लिए नेक प्रेशर हो रहा है। तो अभी ये दिस इज डायरेक्टली रिलेटेड टू द ब्रेन एडिमा। मेनिंजाइटिस में क्या होता है, नेक पेन होता है ना, तो ये सिमिलर यही सिचुएशन हो रही है। So if you just keep on doing it, so next step will be the convulsion. Agar if you just don't do this anything. So even what happens, like if you take too much time in surgery, so this complaint of the patient will be masked, and then you will see the post-operative patient will not wake up nicely. So then you shift to the ICU next day or something. नहीं नहीं, इसका प्रेशर नहीं है, प्रेशर ये जा रहा है उसका प्रेशर। अभी हम एक ही पॉइंट चलाएंगे। दिया मिला जुलम दिया, थोड़ा देखो, थोड़ा थोड़ा दो। अभी हम 15 मिनट में खत्म करते हैं। बस थोड़ा दे दो, जैसे ये ओवर द टॉप बोलते हैं ना, ऐसे करो तो वहाँ पे तो आप ऑपोजिट साइड में हो। हम्म हम्म। इनको 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 सुनो सुनो, इनको सुला रहे हैं तो इनको अभी डिस्टर्ब मत करो। बस ये ऑक्सीजन रखो नियर बाय, और बस चलो, ठीक है, ओके। एक चालू करो, एक चालू करो, कोई बात नहीं। एक 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 इरिगेशन ऑन करो, कोई भी एक करो। नो, so you see the waiting in between the surgery, you will definitely lose your track, because you will always form a kind of a, like some loose clot, and then everything you have to find out. So that's why, like, I just want to start and continue and finish as fast as possible. Grasper there, and like you see, it's very risky to catch the clot with the grasper or something here. Okay. So now you can see this is a dura inside, and see what happens. You see the dura is here nicely. Okay. So what happens, because of the tissue will get the bloody tinge also. So you नहीं, आप हिलो मत, आप हिलोगे नहीं चलेगा, और हमको बताए बगैर हिलोगे तो यहाँ पे प्रॉब्लम हो जाएगी। आपको कुछ भी करना है हमको बता के करना है। नेक में हो रहा है दर्द? कहाँ पे बोल रहे हैं? हम्म? So that's why, like, see, sometime you are able to finish it completely. So that's why it's important to do it on the symptomatic side. At least you are. I'm just trying to remove some here. So you can see the ligamentum flavum here, the lateral side. I'm just trying to. Now you are able to see the lateral margin is more clear.
Yes, sir.
Okay, so this is the lateral margin. This is also the part of the lamina. This is the bony canal. Hmm. So you see, my entry was like this. Now I'm almost going like this.
Yes, sir. So you see, now our job is to remove this phlegm. Then we are done on one side. So we'll see if we are able to continue on the other side, it's okay. Otherwise, we'll finish, because you see, you should always be careful. The patient should be more comfortable, and we should not be able to give more complication. Okay. So you see, this is also from the lateral side. So this is the issue you find with the local anesthesia. But again, I'm very okay, because you see, to me, the patient safety is more important. And you can see we are able to nicely decompress the more and more ligamentum flavum in the lateral area. You can see. You can see how thick is ligamentum flavum here. Yes, sir.
So you see my eye always on the dura. You can see the root is very clear.
Yes, sir. Underneath the ligamentum flavum.
Yeah. So like see, whatever you are pulling it out, you have to be very careful. You have to be very careful. So now you can see the root is more and more visible. So we are slowly we are able to remove the major part of the compression. And this is I am working on the foot end. Okay. So you can see this is the phlegm.
Yes.
I'm going inside and see while I'm pushing it, I have an eye on the dura that I'm not pulling it. So again, I will make a target. You can see the phlegm, the root is okay. So you see, this is the biggest advantage that you can work below the facet and you can remove this is SAP. मैं नीचे हूँ ना नीचे SAP आएगा ना IAP ऊपर हाँ I'm toward the foot end yeah. So this is the SAP. This is the SAP. So if you are below the SAP, so your decompression is adequate. Like say I'm removing this part of the phlegm along with the bone. You can see this one. So this is actual area you want to decompress. Now, SAP. SAP में इतना कर लोगे तो more than enough है. So you see now I'm able to see the root margin. So
Yes,
it
sir.
is finishing here. And now you see if I take this couple of bite here, so this is like having the big impact on patient outcome. Can see? So this tissue is actually inside. I'm just try to be more. So the root is okay. That this is addition now. Yeah. So you see the now is quite okay.
Yes, sir.
Now is quite okay. So I'm just trying to take some of the compression here. So this area is quite difficult for anyone to work on the open surgery because this is quite inside. So you see I'm removing the bone from here. So you can see this is additions because the root is in front of me. I'm okay with that. So again, I go inside. This is the most crucial area over the root where the root is becoming the exiting root. Okay. So you can see the root here is quite okay. So now I'm coming on the upper side. So you can see the root margin here also. So now I change my scope direction like this. So you can see this is the area
Yes, sir.
below the facet and you can see the root here.
Yes, sir. It is well decompressed on ipsilateral side, sir.
Yes. So you see sometime like you may not be able to do the both side or something because patient is not comfortable or because of the lot of bleeding or something, but still like this decompression works for the contralateral side also. Now you
Yes.
see this is I am removing this phlegm from the gutter.
Yes, sir.
This is actually the lateral ligamentum phlegm. Side. You can see.
Yes, sir.
You can see this one. So this is on the edge. This is on the side of the phlegm. And now you see our root is
Root is free. Yes, sir.
completely free. Still, there are some tissues. I just want to work on this. So you see in chronic congestion, there are some inflammatory membranes. Like you see, you can see the complete root here. So there's some inflammatory membrane. So that is adherent, like that is between the dura and the phlegm.
Oh.
This inflammatory membrane will always cover your dura and you will have like a fear. But that is not a big job. You see this phlegm?
Yes,
Now you
sir.
see the root. You can see the root margin here.
Yes, sir.
Very clear. Okay. So you see, this is our aim to clear the root margin. So this camera is, so you can see the margin.
Yes, sir. Root margin we can see.
Okay. So this
Yes.
margin is quite free. This is in the upper side. This is in the lower side. Let me just remove this tissue because this tissue is troubling me a lot. And now you see the root margin here also. Okay, so you can see the root margin on the both side, upper and lower below.
Yes, sir.
Yeah, no, not this one. इसको नहीं छेड़ेंगे अभी. Okay, give me place. This is the opposite side. आप जो बता रहे हो ना, this is the root margin. This is the facet here. So आप देख रहे हो यहाँ पे root margin is clear. So this is a perfect unilateral decompression. मैं just check कर रहा हूँ कि I'm not holding. तो root खींच नहीं रहा है तो I'm okay. समझ रहे हो? If I'm not pulling the root, it's okay. Okay, so now you can see the root is quite free. Okay, so I'm just showing you the original position. This is how we started. So this is upper lamina here. ये upper lamina यहाँ पे है.
Yes, sir.
This is a lateral area.
Yeah.
Sacral is a lateral area. This is all the inflammatory tissue, and this is the root free. Okay, let me just try to go more in. If I can go more in. अब देखो ये जो opposite side करना है ना, तो we have
Yes,
to
sir.
remove this part of the ligamentum flavum. So this is the opposite side. Okay. So let me start it, but I will do it only if the patient is comfortable. Okay.
Yes, sir.
Anupam, मुझे भी यहाँ पे भी थोड़ा निकालना है ये. Because you see, I see in the ipsilateral side, this particular area, there is still I can feel there is still some small compression. So this is a SAP. This is a SAP, and see this is yeah. This is you have to remove it very carefully because you see the root is underneath. But you can see now there will be a big difference in the root decompression because once you remove the SAP, the root is actually compressed in the lateral canal. So you can see now the root is free inside. और दोनों पैरों को दो. अच्छा दूसरा भी लगा दो थोड़ा. चलो तो थोड़ा विजुलाइज कर लेते हैं. So देखो हमने ऑलरेडी 60% जितना तो डिकम्प्रेशन कर दिया है,
Yes, sir.
बिकॉज इसी हमने मिडलैंड से भी थोड़ा डिकम्प्रेस कर दिया है. नाउ आई थिंक वी विल स्टॉप हियर बिकॉज दिस शुड गिव हिम सफिशिएंट रिलीफ. बाद में हुआ तो हम वो करेंगे, बिकॉज मुझे भी थोड़ा इधर भी काम करना है. यू कैन सी नाउ, नाउ दिस रूट इज गोइंग इनसाइड इप्सिलेटरल साइड पे, तो इप्सिलेटरल का अच्छे से काम खत्म कर देते हैं. यू कैन सी द नाइसली
Yes, sir. Nice decompressed roots.
हाँ, लेकिन देखो यहाँ पे भी है ना, ओ ओ ओ ओ ओ, सो ही इज फीलिंग पेन. तो देखो ये काफी अच्छे से डिकम्प्रेस हो चुका है. I'm just trying to pull out this one. So you can see this root is going inside,
Yes, sir.
and this is a soft tissue. So like there is no bony compression here.
No.
I can accept this.
Yes, sir.
Let me still. मेरे को थोड़ा पता चलेगा. When I'm touching, he is able to respond. Wait. तो देखो ये जो है ना,
Hmm.
या ये रूट है, ये कोड है. तो हम अभी एक साइड पे हैं. देखो ये रूट है, तो ये और अंदर जो देख रहे हैं ना, यू कैन सी नाउ दिस इज द एक्सिला एंड दिस इज द शोल्डर. थोड़ा यहाँ पे फ्लेवम है. आई विल ट्राई.
Yes, sir.
चलेगा है. So you see the important lesson is here is also when you want to do it, and suppose if you are not able to complete it, so not to do the complication, because you see that's why we started from the symptomatic side.
Yes, sir.
So at least we will be able to tell that okay, एक side का हो गया है, एक side का बाकी है, because you see, suppose if you are not able to finish it, and then if you end up with a complication, the entire picture will change. एटलीस्ट ये एक साइड का जो कंप्लेन है ना, वो तो विजिबल होगा. एंड आई वांट टू रिमूव दिस फ्लेवम बिकॉज दिस इज, नहीं आप हिलो मत. तो ये तो हमको निकालना पड़ेगा.
Fluid related.
हम्म, क्या हुआ?
House is asking that what complications we are looking for, like fluid related complications, sir.
या फ्लूइड रिलेटेड कॉम्प्लिकेशन. एंड यू सी दिस आर मोस्ट सीरियस, दिस आर नॉट
Yes.
टॉक्ड,
Yes, sir.
एंड पीपल आर इवन नॉट अवेयर ऑल्सो. सो ये अभी है ना, यू सी दिस रूट एंड दिस पर्टिकुलर लिगामेंटम फ्लेवम यहाँ पे. सो इतना निकाल लेते हैं. So at least it will make the complete this one free, because you see patient is constantly complain about the headache. Okay, so we stop one times. Now if I stop again, then this oozing will not let me finish my work. So then you see putting the camera second time, it's such a dangerous thing for us, because you see you don't have a orientation, you don't have idea about the depth, and everything is like is in trouble. So like see this is Kishore, 4 minute rapid. So I'm just trying to remove this lower phlegm as much as possible. And see, sometime what I do, I just break the opposite side ligamentum phlegm
Yes, sir.
from the center. So now this tenting effect will be down, because I say that the spinal stenosis is like a compartment syndrome. So your compartment, if you just break the whole of the roof of the ceiling, then still there is no active compression, and still the patient will do well. So you see, this is already we are on the opposite side.
Yes, sir.
This the bone which we are seeing, the opposite side bone. So you see, this is also a big safety for me because patient is responding. So ये opposite side का है phlegm. So I'm going there and I'm just detaching it. This is opposite phlegm. Okay. So now we will be able to बस थोड़ा पता चलेगा, थोड़ा पता चलेगा. Now you will be able to see the complete code.
Yes, sir.
You see my hand movement and my scope movement.
Yes, sir.
मैं ये opposite side में हूँ, so ये opposite side का भी हमने काफी निकाल दिया है.
Yes, sir.
Okay. So you can see the amount of congestion also there. बहुत congestion है ना. So if I am able to remove this small portion, तो हमारा opposite side भी decompression complete हो गया. Okay, I think we are lucky.
Yes, sir.
So अभी देखो मैं आपको I'll show you the complete code. थोड़ा पता चलेगा. ये देखो ये opposite side code का margin है. You can see. Okay. Now you see if I still want to continue it, I can do this. I can remove this ligament of phlegm.
Only in the lateral recess, sir.
हाँ ये opposite side lateral recess.
Yes, yes. Yeah. This is
देखो
sufficient then. Yeah.
देखो ये है ना. So I break most of my scopes here because I put a lot of traction to hold this. So ठीक है.
Yes, sir.
अभी पूरा ये कोड दिख रहा है ये पूरा.
Yes. Full decompression is done.
ठीक है. तो आई थिंक
Yes, sir. Yes, sir.
थोड़ा भी ज्यादा लालची नहीं होंगे. डॉक्टर अनुपम इज सेइंग मोर देन सफिशिएंट.
नहीं, okay.
नहीं ठीक है ठीक है. देखो यहाँ पे थोड़ा है ना ये कट लो. नहीं नहीं ठीक है ठीक है. चलो. So Dr. Anupam is little worried, but you see now I can show you the entire code. So देखो ये पूरा कोड दिख रहा है, दोनों मार्जिन दिख रहे हैं. Okay, and the code is nicely pulsatile.
Nicely proceeding. Yes, sir.
ओके चलो अभी ड्रेन दे दो, हमारा काम हो गया. अब हम आराम से.
पूरा कॉर्ड है.
ठीक है. ये थोड़ा निकलना तो निकाल सकते हैं लेकिन अभी छोड़ो. चलो निकलना है. चलो ला ला दे दो दे दो दे दो. हाँ अभी आप मुझे 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 2 मिलीमीटर दे. हाँ हाँ नहीं नहीं ठीक है निकाल दे.
हाँ, कर तो दिया. प्रोजेक्ट साइड हो गया. नहीं नहीं, कर साइड. सॉल्व. ये लो स्ट्रिंग बची है बस.
ठीक है अभी.
हो गया.
क्योंकि ये आपके ब्रदर है ना. हाँ ब्रदर है ना, वही वही पूछ रहा हूँ. तो क्या कि सर के ब्रदर है इसके लिए थोड़ा थोड़ा सर वो कर रहे हैं. तो ठीक है कोई बात नहीं. हाँ हाँ थोड़ा थोड़ा और चलेगा ना. ठीक है. चलो 5 to 10 मिनट. देखो इसको कैसे निकालते हैं, आई शो यू. देखो ये लेटरल मार्जिन है ना, इसको ऐसे पकड़ लेने का.
यस सर.
और है ना यू पुट द कैरिसन लाइक दिस. यहाँ से आएगा कैरिसन. ये है ना इसके अंदर जाएगा तो ये थोड़ा बोनी डिकम्प्रेशन भी हो जाएगा. एंड इसको स्कोप को थोड़ा घुमा देंगे तो हमको दिखेगा. रुको, रुको, रुको. नहीं, उससे अगर ज्यादा वो बड़ा होगा ना तो क्या होगा, तो नहीं, कैरिसन का जो बड़ा हो जाएगा ना, देखो ये बड़ा हो जाएगा, जितना ये होगा इतना उसको नीचे डालने के लिए तो वो आपके हाथ में ही नहीं आएगा। सो नाउ लेट मी जस्ट सी दिस। तो देखो ये मार्जिन तो काफी क्लियर है। चलो छोड़ो छोड़ो छोड़ो, चलो ठीक है चलो ओके, बिकॉज चलो ठीक है ठीक, चलो ये तो मस्त है, कोई प्रॉब्लम नहीं, चलो फाइन। सो यू कैन सी नाउ, यू कैन सी
Yes,
द
sir.
पल्सेटाइल को, देखो ये इतना पल्सेटाइल कर रहा है और मुझे कहीं पे किंक किंक नहीं दिख रहा है। सो इफ देयर इज नो किंकिंग यू आर डन, चलो।
Yes, sir.
और ये साइड में रख देने का। और सबसे बड़ी मजा देखो, लाइक सी दोस हु आर ऑर्थोपेडिक न्यूरोसर्जन, तो आपको अभी पेशेंट से बात करने की, अंकल जी ठीक है, जोर से बताओ, यहाँ पे सुनाई नहीं दे रहा। नो प्रॉब्लम, ओके। एंड लाइक सी यू कैन ऑल्सो सी द पेशेंट कैन ऑल्सो, अभी इनसे मैं पूछ भी सकता हूँ, थोड़ा ये पैर ऊपर करो, थोड़ा दोनों पैर ऊपर करो, ओके, वेरी गुड, ये राइट वाला ये लेफ्ट वाला, ओके। डॉक्टर वेदपाल कैन यू सी दिस?
Yes, sir. Yes, sir. Very well.
देखो मैं ये ऐसा बोलता हूँ, ये पेशेंट से ज्यादा अपने लिए पीस ऑफ माइंड है, ठीक है। वो बाद में जाके वो क्या, लाइक सपोज इफ पेशेंट इज हैविंग वीकनेस आफ्टर द सर्जरी, so it's very difficult to explain the relatives, very difficult to explain, क्या जवाब देना ना वही पता नहीं चलेगा।
Yes, sir.
and then you have to create a story कि थोड़ा दिन में हो जाएगा, 4 दिन में हो जाएगा, 5 दिन में हो जाएगा, और रात को खुद को नींद नहीं आएगी, वो भी सही है। और अगर पेशेंट थोड़ा वीआईपी हुआ तो फिर कोर्ट के चक्कर भी चालू हो जाएंगे। so you see, this is what like I always say, that this is a good for us, अपने लिए है। थोड़ा देखो, हाँ हो गए, थोड़ा पेशेंट को थोड़ा तकलीफ पड़ा, ये पड़ा चलता है, लेकिन है ना, वो पेशेंट की सेफ्टी के लिए है। 2 बार ऐसा हुआ कि मैंने कुछ टच किया, देन ही से तो मैं रुक गया, अदरवाइज आई वुड हैव स्ट्रिप द ड्यूरा एंड आई वुड हैव कम आउट।
Yes, sir.
पेन नहीं हुआ ना आपको ज्यादा? ठीक है, चलो, पेशेंट इज ऑल्सो वेरी हैप्पी, पेशेंट इज वेरी कोऑपरेटिव, but you see, like this is a peace of mind, I always say this is a peace of mind for everyone, not only for the surgeon, for the patient relatives। ये अभी इनको 2 घंटे में आराम से चाय पानी पिलाओ, बाथरूम जाना है तो खुद जाओ, और 4 घंटे के बाद इफ ही इज कंफर्टेबल ही कैन वॉक। एक मिनट, आता ना, ट्राई कर लो, चलो। और वेदपाल, आई ऑलवेज लाइक टू पुट दिस ड्रेन,
Yes, sir. Yes, sir.
and you always make sure that the drain should ooze something, so it means your
Yes, sir.
drain is not misplaced।
Yeah, patency is important.
या तो क्या होगा, कई बार ये बाहर आ जाता है, देन लाइक द पर्पस इज नॉट सर्व। सो
Mhm.
तब तक तुम ये स्टिच लेते हो, तब तक ये ड्रेन होना चाहिए। और
Yes,
उसका
sir.
advantage भी ये है कि लाइक इट विल रिमूव द 2 3 4 ml 5 ml 10 ml अप टू, ब्लड निकाल दिया तो पेशेंट का जो ब्लड का जो रूट पे इरिटेशन होगा वो नहीं होगा। सो
Hematoma नहीं बनेगा, हाँ जी सर।
और क्या क्या हिमेटोमा की वजह से कुछ भी हो सकता है, तो ये
हाँ।
मोस्टली माय प्रोटोकॉल इज द नेक्स्ट डे मॉर्निंग और मे बी आफ्टर 4 6 hours,
Yes,
if it
sir.
is not draining more than 20 ml, I will remove it।
Remove it. Yes, sir.
and we are putting a mini wake, तो ये बहुत छोटा सा है, अगर इसके साथ भी पेशेंट को चलाना है तो भी
जी।
आप चला सकते हैं, ओके।
Yes, sir.
So I think this was more of convincing।
Thank you so much, sir. What a wonderful presentation.
Thank you,
Nicely done. Bilateral decompression. I was very happy.
thank you
Thank
very
you so much, sir. Thank you so much.
much, bye। बंद करो, हाँ हाँ, उसी से कल तो निकाल देना, 4 घंटे 6 घंटे रहेगा, 8 घंटे रहेगा, ट्रैक कहाँ से बनेगा? ये ऑलरेडी तुम्हारे पास जगह है तो उसमें से करो ना, एक नया इंसिजन डालने की जरूरत नहीं है, मोस्ट ऑफ द टाइम इफ ये मेरा स्पेशल स्कोप है, बहुत छोटा है, 100 मिलीमीटर का है ये। और इसके रिलेटेड मैंने इंस्ट्रूमेंट भी छोटे बनाए हैं। तो एक बड़े इंस्ट्रूमेंट होते हैं ना, तो तुमको ऐसे करना पड़ता है, ऊपर चढ़ के करना पड़ता है। सो यू आर नॉट कंफर्टेबल, हियर यू आर कंफर्टेबल। ड्रिल ये जो नोवा की है, ये ड्रिल सबसे इम्पोर्टेंट है। और ये ड्रिल है ना, एक ड्रिल 50 केस में चलती है। 50 केस में आपको यूज करते हैं, अभी आप ऐसे करोगे तो टूटेगी। लेकिन जितना आपको बोन, इसको कैरिसन बोन कटर। हम्म वो 90-20 डिग्री का कोई मतलब नहीं है। ये स्विस कंपनी नोवा करके है। ये स्पाइन ड्रिल ही है। हाँ, कॉस्टली। देखो, आप कोई रिलेवेंट क्वेश्चन ही नहीं कर रहे हो। दिस इज नॉट रिलेवेंट। तुम ये बोल रहे हो कि स्विट्जरलैंड बहुत सुंदर है। बराबर, तो स्विट्जरलैंड सुंदर है ही। लेकिन अभी अभी तुम यहाँ पे कश्मीर में हो, तो कश्मीर के बारे में बात करो ना। तो इंटरलेमिनर एंडोस्कोपी पूरा अलग चीज है, इंडिकेशन अलग है, काम अलग है, इंस्ट्रूमेंट अलग है, सब कुछ अलग है। तो इस ये दोनों का कोई वो भी नहीं है। जिसको इंटरलेमिनर करना है उसको इंटरलेमिनर करना है, जिसको ट्रांसफेरमल करना है उसको ट्रांसफेरमल करना है। हो जाए तो हो जाए, उसके लिए प्लान भी तो चाहिए ना। कुछ भी हो सकता है। अभी यहाँ पे एनेस्थेटिस है, उसका लिए सिंपल आंसर ये है कि ये आप ऑपरेट करते हो, ECG लगाया, ये लगाया, ऑक्सीजन लगाया, यहाँ पे एनेस्थेसिया की किट है कि नहीं, इंट्यूबेशन करना है तो है कि नहीं। यानी तो एनेस्थेसिया में सपोज के पहला रूल क्या है, अगर पेशेंट को स्पाइनल देना है, पेशेंट को अगर शॉर्ट जीए देना है, व्हाट इज द फर्स्ट रूल? बैकअप जीए अवेलेबल होना चाहिए ना, ऑक्सीजन अवेलेबल होना चाहिए ना। तो देखो, ये है ना, कोई शॉर्टकट है ही नहीं। एंड शॉर्टकट अगर सोचो तो जो कर रहे हो वही करो। अगर तुमको युद्ध लड़ने जा रहे हो और तुम बोलो मैं लाठी से जाके लड़ूंगा, तो घर पे बैठो। ये कोई चॉइस, मैं वही बता रहा हूँ। कोई न्यूरोसर्जन है, उसको ट्यूमर करना है, माइक्रोस्कोप चाहिए ही चाहिए। अब वो अगर उसमें उसने गड़बड़ी की और नहीं किया और बोला कि नहीं मैं थोड़ा देख लूंगा कर लूंगा, तो वाई वाई यू वांट टू पुट द लाइफ ऑफ द पेशेंट। पेशेंट तुमको बोल ही नहीं रहा कि साहब आप ही दुनिया में अकेले आदमी हो, मेरी सर्जरी करोगे, भेज दो इसको कि भाई मेरे पास इक्विपमेंट नहीं है, ये करेंगे। लेकिन है ना, जब ये अवेलेबिलिटी हो, जब सब हो, तब भी काम करने का। अदरवाइज रिजल्ट कॉम्प्रोमाइज है ना, आपकी इंस्ट्रूमेंट की इनकेपेसिटी की वजह से ही इनिशियली होंगे। देखो, ये मैं कितने कंडीशन लेके बैठा हूँ, 1 2 3 4, ठीक है। यहाँ पे भी 1 2 पड़े होंगे, यानी सब लेके मैं बैठा हूँ। मेरे पास ये पता है कि राउंड शाफ्ट कंडीशन अलग है, ये दूसरा ओवल कंडीशन अलग है। राउंड शाफ्ट जब मैं डालूंगा ना, तो ब्लीडिंग बंद हो जाएगा। समझ रहे हो? तो वो सारी चीजें हैं, वो इम्पोर्टेंट है। तो मेरे लिए, मैं इसको भी लेके आया। मैंने बोला कि नहीं तू आजा, सबको बोलेगा नहीं ये आएगा, क्योंकि मुझे यहाँ पे भी मुझे कंफर्ट चाहिए ना। तो मेरा रिजल्ट मैं अपने कंफर्ट पे दे पाऊंगा। इफ सपोज ये भी नहीं है, तो अभी ये ड्रिल है, चला नहीं चला, ये हो गया ये हो गया, तो कौन देखेगा? तो देखो, एक है ना, ये एक रॉकेट साइंस है, तो उसको रॉकेट साइंस की तरह ही उसको रखो। कॉम्प्रोमाइज करो, ये शेवर वाले ड्रिल, वो क्या बोलते हैं, उसका ड्रिल यूज करो, शेवर ड्रिल यूज करो, कोई मतलब ही नहीं है। तुमको एज नहीं मिल रही, तो तुम यहाँ से कैसे चालू कर सकते हो? समझे? तो और बाद में करो, अभी अभी नहीं है तो। लेकिन देखो, आप समझो कि जब तुमको तुम्हारी फैमिली में तुम्हारा कोई भी